outcome of family planning and HIV service integration implemented by USAID and IFHP in Ethiopia.
Okay, welcome back from the health break, everyone. Okay, I will be presenting the operational research that was conducted in Ethiopia by Pathfinder International. And these are the outlines of my presentation. And the background, Pathfinder is supporting the Ethiopian Ministry of Health in the area of family planning, RH, and MHH, including HIV/AIDS, through its integrated family health program. This is a program implemented by Pathfinder in collaboration and in partnership with JSI and other local NGOs. And among these supporters, FPHIV integration, service integration in public health facilities is one of the programs that Pathfinder is implementing. And the objectives of this study was to determine whether the integration of family planning, counseling, and ART service delivery updates increase contraceptive prevalence and addresses unmet needs. And the other objective is to assess the acceptability, the accessibility to the full range of contraceptive methods that are available in Ethiopia for women who are living with HIV. And the other objective is to assess whether FP counseling for men at HIV clinics affects contraceptive use among female PLHIVs attending at ART clinics. And the methods employed was comparative cross-sectional study. The design was comparative cross-sectional study design. And there were two groups, the intervention and the control, of the comparison groups. And the intervention groups were facilities which are being supported by Pathfinder with the FPHIV integration. And the control groups or the comparison groups were facilities which are only providing ART services. And the study population for this research were female PLHIVs, and again who are on ART. And the data collection was through interviews with structured questionnaire and record reviews, and the sampling was a perspective sampling. And among the survey respondents, this much amount of clients were participated in the research, and 1,430 had complete information on contraceptive use and age. And this amount of the clients from intervention and comparison sites. And when we come to the results, this is the socio-demographic characteristics of the respondents, of which educational background and marital status, and the clients, the participants were, when you see the characteristics of respondents' marital status, both single, married, and widowed, divorced clients were involved. And when we see among the results, the unmet needs among the intervention facilities or clients who are following ART in the intervention areas, their unmet need was found to be 9.9, and in the comparison group it was 12.3. And it sounds significant. And the other result was the contraceptive use in the intervention area by these clients, women who are living with HIV, was 53.2, and in the control area was 44.5, and also it can be linked with the previous result. And when we see the contraceptive method mix of these clients, as you can see from this slide, most of the ART clients choose to use injectables than others. Actually, this is evidenced by the Ethiopian Demographic and Health Survey, which was conducted in 2010. And among the modern contraceptive methods, much of the clients choose to use injectables than the other methods. And you can see also from this slide that both in the intervention and comparison groups, injectables are the mostly used contraceptive methods, and the next contraceptive is condoms. Unlike the EDHS result, in EDHS the second most used contraceptive method is the implants in Ethiopia, but you can see that most of the clients are choosing condoms as a contraceptive. And when we see the use of long-acting and permanent methods by women who wish to limit births, in the study groups who are using long-acting and permanent methods are 13.1%, and in the control groups 26.6%. So the control, clients who are following ART treatment in the control groups prefer to use long-acting methods than short-acting. So when we come to the conclusions, unmet need for family planning is low among women living with HIV and IFHP service sites. And these facilities with ZP services integrated into ART service outlets had higher levels of contraceptive use. And use of long-acting and permanent methods was more common in comparison sites. So these are some of the conclusions. And the recommendation is intervention should be scaled up to other facilities, which is obvious. And further efforts are needed to increase use of long-acting and permanent methods among women living with HIV. And our acknowledgement goes to IFHP Ethiopia field office staffs and other partners who have collaborated in conducting this. Thank you very much.
Thank you very much for your presentation, Minister, and thank you for keeping to time. So it's my pleasure now to introduce our second speaker. She's had a busy afternoon. It's a pleasure to introduce Susan Adamchak back to present. Just to remind you, she's a scientist with FHI 360. She works under the Health Services Research Department in the headquarters in North Carolina in the US. Over to you, Susan.
You're going to start thinking this is all Susan all the time. It's not.
Back from popular demand.
My thanks to the previous speaker for introducing this topic so well, because I'm just going to build, I hope, on what he just presented about unmet need among women in Ethiopia. I'd like to acknowledge my co-authors, Barbara Janowitz and Emily Keyes. Barbara is recently retired from FHI. Emily works in the same division that I do in health services research. The very fundamental and basic message that I want to convey to you today, or that I'd like you to take away, I think many of us are familiar with the concept of unmet need. Can you raise your hand? How many have heard of unmet need for family planning? If you haven't, don't worry about it. So most of us have an idea. Now, let me ask again, when you think of sources of information about unmet need, how frequently is the first source to think of the demographic and health surveys? Okay. What I'd like to talk with you about today is what kinds of decisions do we need to make to use the knowledge that we've gained first world fertility surveys and demographic health surveys. This information has been part of demographers' consciousness for 30 years now. And with the evolution of the AIDS epidemic, as more women have been enrolled on care and treatment, and we've seen women returning with unintended pregnancies despite their routine contact with health services, we've realized that we need a better way of measuring unmet need, not at the national level, not at the population-based level that we find is done through the demographic health surveys, but at a lower level, at the level of the individual women reaching our services. So that's the bottom line message I'd like you to reflect on as I speak with you today. So what you're looking at is a very abbreviated version of the basic algorithm that's used to estimate unmet need. So typically, according to the DHS model or algorithm, we would normally start with currently married women who are not using contraception, and then we consider whether they're pregnant or not pregnant. If they're pregnant, what was the intended status of that pregnancy? If they're not pregnant, are they fecund and able to have a pregnancy, or are they infecund? If they're fecund, when do they want that pregnancy? Do they want it soon? Do they want it later? Or want no more? And then we talk about unmet need relative to the need for spacing, limiting in these two populations, okay, of women who are currently pregnant and those who are not. Now, when we're thinking about women accessing care and treatment services, we're not sure. What we propose is that there's several components that need a slightly different point of view when we're looking at women who are accessing health services. At the very first, there's an assumption in the DHS calculations that all married women are sexually active. Well, I'll speak with you later, but is that an accurate assumption if you're talking about a population of women with HIV? I will argue that no, it's probably not. What about, the next issue is whether those women who are or are not sexually active using contraception. We know that for many, many years, HIV programs in particular have promoted the use of condoms. Now, I will raise my hand, and if you ask me, have I used condoms consistently and correctly every time I should have used them? Is that true, a true statement or a false statement? In my case, I have to admit it's probably false, that there are a few times when I did not use a condom consistently and correctly. Anybody else want to raise their hand to that same question? A lot of us who are in this field, who should know better, don't do what we're preaching to other people that they should do. Okay? So if a woman says she's using contraception, but she's using condoms, is that sufficient? Should we take that as the be-all and the end-all? Okay. Oops, sorry. All right. In the algorithm that we're familiar with previously, if a woman has a mistimed or unwanted pregnancy, we also say that she has unmet need for family planning. However, if you are in an ART clinic and the woman is sitting there 8 months pregnant, does she need family planning at that moment? We don't think so. So should she be included in the calculations of unmet need? And finally, the DHS typically uses a timeline of 2 years. Do you want to have your next pregnancy within 2 years if you're not currently having one? Well, is that a reasonable period of time? Have we tested that in the clinical setting? So I'm going to skip this very quickly because I think many of you are familiar with the 4-pronged approach of reducing mother-to-child transmission. Clearly, the prevention of unintended pregnancies among HIV-positive women plays a very important role in this strategy. So our key question is, how can we alter this algorithm in order to, so that providers can better respond to the family planning needs of women? We want to suggest that we need to consider both recent recent past and future plans for sexual activity. Is it sufficient to just say, have you had sex in the last 3 months? We'll see. Desire for children in the near and distant future, and the use effectiveness of contraceptive methods all need to be considered. Very quickly, we pulled data from a multi-country study. You can see the 5 countries who were mentioned noted here. Today I'm going to report on 2 samples of women, those from care and treatment and in counseling and testing. And we calculated unmet need for family planning based on different assumptions about sexual activity and pregnancy desires. So these are 5 questions that we posed regarding this logic. Is it reasonable to assume that all married women are sexually active? Does the lack of sexual activity today imply that women have no need for contraception? How should we treat current pregnancies? What time horizon should we use? And should we consider method mix? Okay. Now, I'm sure you probably can't read this, but trust me that this table represents each panel represents the major elements of that figure that I showed in terms of the measurement of unmet need. I'll add that I do have copies of the handout, and I'll put those at the FHI 360 booth, so if you want to look at these numbers more carefully, you can. The major point to take away from this slide is that among women in union, you see that there's, the first column is actually assuming that all women are sexually active. In the second column, we delete, or we look at specifically, so it's in the red circle, women who did not have sex in the last 3 months. So of those who are not using contraception, half of them did not have sex during the prior 3 months. And then as we move through the panel, we gradually reduce among those who are not contracepting and are sexually active, who is pregnant, who reported themselves, they believe themselves to be infertile, who does not want a child in the next several years, and the intendedness of their pregnancy. The bottom line is that if we assume that everyone is sexually active, we come up with an estimate of unmet need of 26%. If we do take sexual activity into account, that level of unmet need drops to only 10%. Important for our program planning. Similar figures, and in the interest of time, I won't go through all these, but this is for our population of women in counseling and testing. Now, I asked about, is it sufficient to just consider past sexual activity? Have you been sexually active in the past 3 months? If a woman says no, we say, okay, she doesn't have a need for family planning. However, when we looked at our counseling and testing clients, you can see the blue part of the pie chart that's exploded out, and the red are those women who are being tested because they want to get married or because they want to begin or resume a sexual relationship. So nearly 50% of the group said that they were not having sex right now, but they're going to start tomorrow. So do we need to think about their unmet need or their need for family planning? This slide presents some information on the timing and when people want children relative to their contraceptive use. You see that even women who do want a child, which are the first 2 sets of bars here, contraceptive use, which is the blue line, is very high, even among women who are saying they want another child. Clearly they don't want that child the day after tomorrow, or before that cycle of pill runs out, or before they get that implant taken. We'd also argue that we need to consider the efficacy of family planning methods. And this chart just shows methods going from the bottom, those less effective methods, such as withdrawal of spermicides, up to more effective methods. We see that the method mix in these 2 groups of women is very different. Among women in care and treatment, with women who already have at least 3 children, who we would normally think of as being candidates for a method of family planning, an effective method of family planning, a long-acting method of family planning, are at least 40% of them are relying on condoms alone. In care and treatment, we see 50% are relying on injectables. The message here also also is that those women are not using dual protection and are not making an effort to protect themselves from HIV transmission. So I'm going to return just to my final, going back to our illustration, where, to summarize, I would just say that providers do not make assumptions about sexual activity. We do need to make assumptions about family planning use effectiveness. We need to better consider point number 4, the timing of a next pregnancy. And for women who are currently pregnant, we would not include them as part of our Unmet calculation at the clinical level, but say they do need to have a plan in place for their postpartum. So, that just summarizes what we just said. I will leave it to you, and as I said, if you want some more information, you can pick up a copy of the handbook. Thank you, and my apologies for running.
Thank you very much. Okay, so we're over to our third speaker now, who is... it's my pleasure to welcome Mwale to present. She's a senior PNTCT officer based in Central Region of Zambia. She works for the ZPCT II program as part of IFHP 60. She will be presenting on testing the feasibility of integrating family planning and HIV/AIDS services in the ZPCT II partnership. So very shortly.
Good afternoon, ladies and gentlemen. I'm going to talk about testing the feasibility of integrating family planning in HIV services in the ZPCT II partnership, that is Zambia. A list of contributors to the study are listed as shown, and the background is as outlined. I'll look at the background itself. Rationale, methods, results, challenges, and lessons learned. And the background, ZPCT II is a 5-year contract funded by EDFA through USAID from 2009, and it's going to May 2014. The prime funder or prime partner is IFHP 360, and our aim, we do support the Ministry of Health through strengthening and expanding HIV-related services in the 5 provinces. There it's showing in the 5, but actually it's 6. We have had a new province added into. So the objectives include expand and scale up HIV services, which includes counseling and testing, PMTCT, ART, MC, lab, and pharmacy. So we collaborate with other partners in providing comprehensive HIV services. We do capacity building through Ministry of Health at various levels. That is at facility level, that is health center level, district, up to provincial level. Then we have also private partnership relationship, whereby the private health centers are supported with the HIV/AIDS related services provision. And then we also integrate family planning services and other HIV-related services at various levels of health provision. So the map here shows where we are with our coverage, which is the ZPCT II coverage. It's marked in green. We are in 6 provinces, and we are covering 371 public facilities and 17 private health centers. And then the rationale for family planning integration with HIV. We have seen that family planning is important in the prevention of mother-to-child transmission of HIV and reducing the incidence of pediatric HIV. Then we have a high fertility rate of 6.2, and we have high unmet needs. And so far, from our evidence, we have only about 27% having to access family planning services. And then our prevalence rates we are at 14.3%, and we have a high mortality rate of a ratio of 470 per 100 live dates. Even though family planning is known as an important HIV prevention tool, it has been underutilized most of the times. Reducing the unmet needs for family planning is a key objective of the Zambia National PMTCT Protocol Guideline. Integrated services are supported by donors, which includes PEPFAR. The methods that we used, we did the capacity building, whereby we trained healthcare providers who are trained in counseling and testing. We trained them, the family planning providers, we trained them in counseling and testing. And then we trained the PMTCT providers in family planning. And then, of course, we trained healthcare workers in ART sites with family planning. Then we also followed with on-site mentorship, that is post-training. We followed it up with mentorship. Then distribution of job aids, standardized family planning job aids. And then we also established counseling and testing corners within family planning services areas. We did demand creation through community mobilization. That is, we also did demand creation during antenatal visits. We talked about the importance of family planning. And then during post-test counseling, regardless of the HIV test results, family planning was equally discussed and emphasized. Then to monitor the outcomes of the interventions, we analyzed routine program data from 16 health facilities, and below are the indicators that we looked at, which is the number of clients provided with CT, number of family planning clients, then the number of CT clients referred to family planning, and we also looked at the number of ART clients that we are providing with FP services. So we used a pre- and post-intervention cross-sectional design. This covered the period of 18 months before and after intervention. Then we assessed the number of family planning acceptors using a chart, as we will just see below. Then we looked at the results includes, we trained 17 healthcare workers, 25 community volunteers who were trained in CT and healthcare workers in family planning. So we also saw an increase in the number of CT clients, ART clients prepared for FP, and also we saw an increase in the number of FP clients receiving CT services. This slide just shows the increase of clients who were offered, who were referred to family planning from CT. And then we see in blue, this was before, and in red, it was after. We saw a sharp increase in that area. Then we look at the slide. This one, we are looking at CT clients, ART clients who were referred from the CT from ART to family planning, and also received the ART, the family planning, a method of family planning at the facility. This one just indicates the number. We saw an increase of the number of FP clients who received CT services. So the lessons learned, we have seen that it is feasible to advance family planning HIV integration in PEPFAR-supported programs by incorporating content on FP in the core activities that support HIV service delivery. And of course, we may need to task shift some elements to the community volunteers in the face of human resource constraints. Then, of course, it requires capacity building for both healthcare workers and community volunteers.